welcome. I'd like to say good evening or perhaps good morning, good afternoon, good night to all of you joining us for the GRAPPA Spartan Psoriatic Arthritis, Psoriasis, and Axial Spondyloarthritis Global Education Virtual Seminar. Today we are in part 3 of 6 of this complimentary 6-part series consisting of 90-minute seminars on psoriatic arthritis, psoriasis, and axial disease. And our intent is to hear from a lineup of experts and patients that will be that have been providing and will continue to provide in the series up-to-date knowledge and skills to advance your comfort and skills in managing patients with psoriatic arthritis, psoriasis, and axial spondyloarthritis. I'd like to say thank you very much to GRAPPA and to Spartan, and thank you to our sponsor, Pfizer, for supporting this activity. We'd like this to be as interactive as possible. You will have a lot of opportunity to ask questions in the chat, and I highly encourage you to put them in as you go through listening to the videos, and then we will get to those in the discussion that follows each segment. So this is part 3 of 6. This one is on assessing disease activity in clinical practice, advice from our experts. Part 1 will be the patient perspective, and this will include 2 of our patient research partners, Jeffrey Chow, and he's joining us from Hong Kong, and Martin DeWitt from the Netherlands, also patient research partner. And then we will have assessment on psoriatic arthritis, which will be, and I'll introduce each of the faculty as we go through, but the first is Katie Leung and Laura Coates. Katie from Singapore, who's an associate professor of rheumatology and immunology, and Laura Coates, who is associate professor of rheumatology in Oxford. Then we'll go into the second part on assessing skin disease, psoriasis, which will be from myself. I'm a professor and chair at the University of Utah in dermatology, and Dr. Joe Marula, who is a dermatologist and a rheumatologist at the Brigham in Boston, Massachusetts. And then part 3 will be on assessing axial spondyloarthritis from Dr. Atul Deodar, who is from Oregon Health Sciences, professor of medicine and the medical director for the rheumatology clinics there. And with that, I'm going to go ahead and, you can see here that we also have a live moderated chat between each of the segments and at the end. This is our disclosure slide. We have, so you can kind of peruse those. I will not read them to you. And we're going to go ahead and start up in session 1. So we'll start with a couple of questions. So these are pre-question. This is pre-question number 1. So which one of these measures assesses the impact of the disease rather than disease activity? Is it the PSARC, the PASDAS, the PSED, or the MDA? I'll give you about 10 seconds to think about it and answer the question. And 3 more seconds, 3, 2, 1, and we'll go to the next one. All right, and pre-question number 2, which items are included in the RAPID-3 assessment tool? Is it the tender joint count, swollen joint count, and PASI, the global VAS, pain VAS, and MDHAQ or MDHAC, the MDA and PSED, or the tender joint count, swollen joint count, and enthesitis? So which is the RAPID-3? Give you a few more seconds here. And 3, 2, 1. All right. So we'll go ahead and start the first video.
Hi, I'm Jeffrey Chow, a patient research partner from Hong Kong. I was diagnosed with PSA in 2003, and now I need to see the doctor every 6 months with my blood test every 3 months. I'm also involved in a PSA patient group with more than 100 members.
Hi, Jeffrey. My name is Maarten de Wit, and I live in the Netherlands. I have psoriatic arthritis for more than 40 years. And I also have 3 children who are affected with psoriasis. And one of my children also is diagnosed with psoriatic arthritis. Jeffrey, I was just wondering, if I ask my children what their physician told them, there are always several questions for which there was no time during the consultation. How is that in Hong Kong?
From our experience in Hong Kong, time is very limited in every clinical visit. Patients may find it difficult to articulate a full picture of their health situations to the doctor right in the meeting. I think it will be good for patients to have the chance to write down their situation, maybe with the help of some sort of forms or questionnaire, and give to the doctor beforehand, just like we do with our blood tests. The physician receives the result also before the consultation. I think this practice will save time and give a fuller picture of the patient's health situation. Martin, do you see a solution for the lack of time?
Yes, I think that the use of a kind of form, as you said, or a kind of patient questionnaire could be very helpful. It could save time and improve the conversation between the physician and the patient. And for instance, the PSAID, the psoriatic arthritis impact of disease score, has been specifically developed by patients and for patients. And if a patient fills in this questionnaire before a visit, the answers can function like a kind of agenda for the consultation. And in the Netherlands, there are several hospitals that are collecting this kind of information online by use of a tablet in the waiting room. And the treating physician can immediately see when there are problems and so what needs to be discussed. And then it might also become visible that the opinion of the patients is sometimes different from that of the physician. Jeffrey, do you recognize this discrepancy in the assessment of the health situation between the patient and the doctors?
Yeah, our patient group does have this kind of discrepancy experience. One of my patient members felt that his situation was getting worse because of the fatigue, pain, and the extent of damage in some joints that was getting more serious. However, the doctor, based on those test results, which showed that all the indexes are satisfactory, decided to keep the same medical treatment without any changes. Because the next clinical visit will be in a few months, the patient worried that his situation will continue to deteriorate.
Yeah. Well, I agree. And I think even when a change of medication will maybe not be the right answer, I think the physician can think about other, probably also non-pharmacological options to address the remaining symptoms of the patients. Yeah. And maybe also consider referral to other health professionals. So thanks for your answers and for this talk. And I think it was a great opportunity to share some of our concerns from a patient perspective.
Good day, everyone. My name is Katie Leung. I'm from Singapore General Hospital. Welcome to this Grappa Spartan Global Education virtual seminar. Today, me and Laura Coase are presenting to you how to assess disease activity in clinical practice for psoriatic arthritis. The assessment of disease activity in psoriatic arthritis can be challenging because of the diversity in manifestations. Psoriatic arthritis can affect the peripheral joints, including the distal interphalangeal joints, and also the axial joints. There are also enthesitis and dactylitis, the skin disease and nail disease. It can affect the quality of life and physical function, and of course the other comorbidities. The outcome measure in rheumatology, OMERACT, has developed a framework to describe measurement in clinical trials. Very easy concept is what to measure and how to measure them. The GRAPPA has spearheaded the PSA core domain set update in 2016, incorporating the opinion of doctors as well as patients. In this onion, you can see that in the inner circle, there has 8 domains that has been graded as important to be measured in every clinical trials. And now we are also doing the PSA core measurement set using this very stringent criteria, OMERACT filter 2.1. And you can see that some of the instrument has been going through this filter 2.1 to be endorsed. I'd like to highlight to you that there are differences in the purpose of assessment in clinical trial as compared to clinical practice. In clinical trial setting, we are assessing disease activity in different domains for the purpose of monitoring the drug response. Whereas in clinical practice, we are doing a comprehensive examination to understand the psoriatic arthritis disease and the impact to patient. These information are necessary to make a judgment to see whether the treatment is appropriate or needed a change. As for measurement in clinical practice, we also look at what to measure and how to measure them. What we are measuring is muscular disease activity, including that in the peripheral joint, enthesitis, dactylitis, spine, and skin, and the impact of disease. Here is some of the examples on how to assess them. But the main purpose of this assessment is to see whether this patient is active in the disease or not, whether the treatment target is achieved, how is the impact of the disease, and that's help us to make a decision whether the treatment is appropriate or needs some adjustment. Of course, life can be easier if we have an HbA1c as if we have in diabetes. However, we don't have that in psoriatic arthritis. The traditional ESR and CRP are not elevated in many patients who have active disease. From our systematic literature review, we find that these two biomarkers are not perfect for the assessment of disease activity. For assessing disease activity in the peripheral joints, physical examination remains very important. For psoriatic arthritis, we are looking at the 66 swollen joint count and the 68 tender joint count. I can understand the sentiments of doing a 66 and 68 joint count in a very busy clinic. The question is whether reduced joint counts, such as the 28 joint counts commonly used in rheumatoid arthritis, can represent the disease activity in psoriatic arthritis. Showing in these two graphs are data from the COPA trial. Red are those covered by the 28 joint counts, whereas you can see the blue are those that is missed in the 28 joint counts. So majority of the time are joints in the lower limb that has been missed. So in OMERACT term, the 28 joint count is not having the domain match necessary to measure the disease activity in psoriatic arthritis. Here are some tips I can offer for doing the joint count, enthesitis, and dactylitis in very busy clinic. The first thing to do is get the setting right. I always find a footrest so the patients will take off the shoes and rest the leg on it before you examine them. So with some training, the patients are more likely to be willing to take off the shoes and let you examine. The second thing to do is develop a system in physical exam so that you are not going to miss out things. So I always start with wrists and fingers, and I will always observe the symmetry of the digit for dactylitis. Then I go up to the elbow, so I will remember the epicondyles for enthesitis. Then I go up to the shoulder and not forget the supraspinatus there. and then the sternoclavicular joint and temporal mandibular joint. Then I go down to the knee. There are some enthesitis points around the knee as well. Then I go down to the feet and also have a look at the symmetry of the toes for dactylitis. Then not to forget the Achilles and plantar fascia. Then I get the patient to stand, and then I examine the enthesial points around the hip. With more practice, you will be more familiar with the system and not to miss anything. I think visualization helps a lot in the documentation process. This is what we have in the electronic medical system, that we can indicate with a dot where are the joints swollen and tender. And I can use a stroke to indicate that it's dactylitis. For the enthesitis, I also create some kind of diagram to remind me and check the box. And this kind of visualization always help me to hasten up the documentation process. Of course, in the good old days where we all use paper and pencil, this kind of chalk was very useful. You can also use sticky labels for documentations. For the assessment of dactylitis, the most simple way is just to count the number of digits that are swollen. It is the base of the digit that we are assessing. We also assess the tenderness to say that it is an active dactylitis versus some are swollen but no tenderness. We call it chronic dactylitis. You can do the measurement by using a dactylometer as indicated in this picture, and measurement is at the base of the digit. If you don't have a dactylometer, a simple measuring tape will also serve the purpose. Of course, there is more sophisticated dactylitis indexes that has been used in research. Enthesiocytes are where the tendon insert onto the bone. For the assessment of clinical enthesitis, we put pressure onto these enthesiocytes. So the pressure is just enough to blanch the tip of your fingernail, which is equivalent to 4 kilo per cm square. Listed in this table are some of the examples for assessment of clinical enthesitis. And I'd like to highlight two popular ones for enthesitis, including the Least Enthesitis Index and the SPARC. The Least Enthesitis Index is very easy to do, only 6 points, including the lateral epicondyle of elbow, medial condyle of femur, and Achilles tendon insertion sites. Whereas the SPARC, you have a little bit more points on every site. So it's always a trade-off between lower number of points, which is easier to do, and higher number of points, which is more sensitive to change. From this point onwards, I will hand it over to Laura to continue the discussions.
Thank you, Katie. So I'm going to carry on speaking initially about assessment of psoriasis. The most common measure is the PASI score, which you can see here on the left, where the body is divided into 4 areas, and each area has a score for erythema, scaling, and induration. That's very widely used, but a little bit cumbersome to use in practice. And in practice, certainly in our clinic, we use the body surface area, where we look at the percentage of the body covered with psoriasis, estimated by one palm being 1% of the body surface area. There are also measures looking at target lesions or a global rating of psoriasis on a simple semi-quantitative scale. When we think about measuring impact of disease, in the core set you can see physical function, health-related quality of life, fatigue and the patient global listed as core domains, but there are additional measures of impact in the middle circle and the research agenda, because there are really myriad ways that this disease impacts on individual patients. In terms of measuring PROs, I think it's a really important part both of research studies and of normal clinical practice. We can do this in a paper and pencil format with simple paper forms that patients fill in either before they come to the clinic, by post, or when they arrive at the clinic. And it's obviously much easier to do that if they're in designated clinics, because then you know which questionnaires to give to which patient. They can also be done on a variety of electronic platforms, sending text messages or emails before the appointment and patients completing these remotely. One of the most commonly used PROs now is the Psoriatic Arthritis Impact of Disease score, which is a patient-derived instrument that measures impact across a high variety of domains, with the top 12 shown here. These are weighted differently depending on the impact on patients' lives, and there are cut points for disease control or disease impact control that can be used in clinic to get an idea of how much the disease is impacting on an individual. When we think about treating to target, there are a number of different targets that can be used, but the one recommended by GRAPPA is the MDA criteria and the associated very low or VLDA criteria. These require an assessment of joint counts, patient global, pain and HAQ, enthesial sites, and an assessment of psoriasis, most commonly done using the body surface area. Ideally, patients should achieve all of the cut points shown here, but minimal disease activity is defined by achieving at least 5 of these 7 cut points. When we do treat to target using the minimal disease activity, it's been shown to improve outcomes in the TACOPA trial with a higher chance to achieve MDA, joint outcomes like ACR 20, 50 and 70, PASI scores and the HAQ. It also has prognostic relevance, with the majority of patients who achieve MDA having no radiographic progression, and sustained MDA also associated with a protective effect on plaque progression in terms of cardiovascular risk. The GRAPPA app is available free for use for any clinicians and is available in 12 different languages for the patient-facing aspects of this. This includes a calculator to calculate MDA and perform treat to target in clinic, as well as the PSAID questionnaire, which I mentioned before, PASI and body surface area calculators, and a PEST questionnaire to screen for psoriatic arthritis. You can see here screenshots from the MDA calculator, where you enter in the different outcomes in MDA, and on the far right you can see whether patients have achieved MDA, VLDA or neither, and it tells you which items are controlled and which items remain high, so that you can focus your treatment appropriately. This shows screenshots from the PASI calculator, where you can see the different areas defined on a body map, and then when you're scoring the erythema, scaling and induration, there are photographs shown here at the bottom of the screen to highlight a standard level of disease for those different scores from 0 to 4. There are a number of composite measures which are predominantly used in research studies, but are sometimes also incorporated in the clinic. Traditionally, we've used measures borrowed from rheumatoid arthritis, such as the ACR response criteria and the DAS28, but these are not optimal, particularly when they involve a reduced joint count like a 28 joint count, which doesn't reflect disease activity well in psoriatic arthritis. We have newer measures now, the PSARC, which has been used in much older trials but is PSA specific and covers the 68-66 joint count. Newer measures that cover multiple aspects of disease activity across the different domains of psoriatic arthritis, including the CPDI, the PASDAS and the GRACE. And other response measures such as the DAPSA, which focuses particularly on peripheral arthritis, and the MDA target for treatment, which you've heard about previously. Measures typically used in clinic also include the RAPID-3. This was developed specifically for use in clinical practice and is applicable across a number of different types of musculoskeletal disease. This includes 3 dimensions and is filled in by the patient. It measures physical abilities using an MD-HAQ, a pain score, and measures of overall health. And this is combined to give a quick score, which gives you an idea of symptomatology in these patients. It is, however, designed to be complemented by a physical assessment by a physician. When we think about the standard assessments for inflammatory arthritis, this is the ICHOM standard set for inflammatory arthritis, which you can see overlaps quite significantly with the core domain sets produced by OMRACT, looking at pain, fatigue, limitation of activity, and more wider impact of disease. So in summary, when we think about these measurements in clinical practice, it's important that we consider both disease activity and the impact of that disease activity. When we're measuring disease activity, we need to be addressing this across the different domains of psoriatic arthritis, and you can see here suggested outcome measures to assess joint disease, enthesitis, dactylitis, the spine and the skin. These measures in the different domains can then be used as a target of treatment, for example, calculating the MDA criteria, so that we can ensure that we are minimising inflammation in order to maximise people's outcomes long term. It's important as well that we think about the impact of disease, and the easiest way we believe to do this is using the PSAID questionnaire, which covers a wide variety of different impacts of the disease in one relatively simple questionnaire, and this is available in a number of different languages. When we're then making medical decisions in clinic, we're taking into account whether somebody's disease activity is controlled appropriately and whether they've achieved a target of treatment, the level of the impact of disease that they're suffering, any side effects of any treatment, and then thinking about whether treatment needs to be changed and incorporating shared decision making into that discussion with the patient.
All right, we're going to go ahead with the post-test questions, and then we'll have a very short discussion with one of the speakers that I didn't introduce, Philip Meese. So that. So go ahead, and they'll give you a few seconds to answer post question number 1. Which one of these measures assesses the impact of the disease rather than disease activity? PSARC, PASDAS, PSED, or MDA? All right, 3, 2, 1. Closed. So, okay. So we have majority of the group answering the correct question, which is the PSED. As you heard, this is a 9 or 12 point questionnaire that it assesses impact. All the rest of them, MDAs, composite, PSARC, PASDAS, are disease activity scores. Next question, post question number 2. Which items are included in the RAPID-3 assessment tool? The tender joint count, swollen joint count, PASI, the global VAS, pain VAS, and MD-HAC, the MDA and PSED, or tender joint count, swollen joint count, and enthesitis. Give you 3, 2, 1, and we'll go to our response. So again, the majority got the answer correct, which is the global VAS, the pain VAS, and the MD-HAC. And the other ones are not RAPID-3. They are all important assessment tools, as you heard about already, but they are not the 3 points of the RAPID-3. So I'd like to bring into the discussion now Dr. Philip Meese, who I apologize I did not introduce at the outset. And so Philip is a clinical professor of medicine at the University of Washington and director of the Rheumatology Research Unit at Swedish Medical in Seattle, Washington. Welcome. And Jeffrey Chow, who is one of our patient research partner presenters, who's presenting early in the morning in Hong Kong. Welcome to you both. And I'm going to jump right into the chat. And I'm going to start with, first of all, Samar Gupta's question, which is about using practical outcome measures in a busy general rheumatology clinic day to day. Do you need to use different measures to assess all the manifestations, or can you focus specifically on one area like the LEI for a patient with predominant enthesitis? So Philip, I'll let you start there.
Sure. So one of the things that I have come to appreciate is how easy it is to do the minimal disease activity and VLDA, very low disease activity measure. And all of the folks in our practice, including nurse practitioners and physician assistants, do these measures. And literally it takes, I'm going to say, something about 120 seconds to do the MDA. And there's a reason to do it, and that is patients really appreciate it. They love the fact that you're paying attention to them in this more comprehensive and holistic way. They love the fact that there's a quantitative measure. I happen to work in a city where there's a huge number of techies, Microsoft and Amazon and so on. And they love having spreadsheets which show the progress or lack of progress of their disease and want to see that we're doing something about it. So it's really easy. Tender and swollen joint count, you're going to do that anyway as a rheumatologist. While you're doing it, you've got the few enthesitis assessments of the leads. Here's 1% of body surface area, quick guesstimate of the patient's skin, and then just say, on a scale of 0 to 10, how much pain are you having and how are you doing? The only item that's a problem is the hack, because the patient has to fill out a questionnaire, you have to score it. So what I do, I cheat. I do what we call a Brooklyn hack. How are you doing? And I ask a few questions about physical function, and you can tell right away. Are they really pretty much functioning normally or not? There you have it. That's the MDA, and the patients love it.
And in Jeffrey and Martin's video, they talked about the desire of the patients to have either a written questionnaire or perhaps one that could be done ahead of time. And somebody in the chat, Jean, thank you very much for asking this question. How could we do better at this? And Jeffrey, maybe you could tell me if there's a way that they're doing that in Hong Kong, and then I'm going to say how we're doing it in Utah.
I think it would be better if before the consultation, I would suggest patient to prepare and write down what is important to tell the doctor about his or her health situation. And I think it would be good if it can send it to the doctor beforehand. But in Hong Kong, we can't do that. We don't have to do that. But during the consultation, I think just like I love to see Philip, because I think patient may need an inviting environment for them to express their situation and concern. And in Hong Kong, the time is very limited in each visit. So if we see the doctor, they are very busy in watching the computer and are very hurry to finish the consultation, I think it would discourage the patient to express themselves. But on the other hand, just like Philip, the way a warm welcome with eye contact in the beginning may be well enough. And also you can tell, as a patient, you can tell they are doing the examination very, they pay attention on you, and it makes you feel so much better, I love to see Philip in the next consultation.
So I would love to pair you up one of these days. In the University of Utah, we have a pretty progressive electronic health record group that has built patient questionnaires that allow the patients to not only kind of fill in part of the note, really the history, present illness, but also questionnaires that you can either send out ahead. In my video, which you'll see next, at the end, I very quickly mentioned the Skindex, which is a skin quality of life impact instrument. And what I find really interesting about using it is that the patients fill it out within the week of their appointment, and then I can do their quick disease assessment. Obviously, I'm a dermatologist, so I do mostly the psoriasis side of it. But then I can look at those scores, and if they're not like on point, like if I think they're really close to 0% and their scores are really high, I can ask more about it. Like, hey, your scores reflect something a little different. What's going on? It can be open-ended. So I think in the next segment, after we do our questions, and Philip, I'll let you have a closing word here. Maybe people can put into the chat how they're handling patient-reported, questionnaires in their systems, or maybe they're not. But if you have great ideas, throw them in the chat, and then of course throw your questions in as we do the video. So Philip, any last comments here?
So I think there's a natural fear on the part of physicians that if they allow or open up too much to letting patients just voice their concerns, where does it end? How do we bring this to a close? And it's a fine balance between needing to get on with your day and see the next patient versus listening. I think it's important when you're first getting to know a patient to have eye contact, to get away from the keyboard, to get to know a little bit about the patient. And then that upfront investment of time really pays off, because there are going to be times later on when you're hurried, you have to do your thing and move it, but you've already established a certain trust and relationship with the patient. And so I think that it's important to take the time, especially up front when you're developing a relationship, because these are long-term relationships. Believe it or not, I am seeing patients that I saw back in the 1980s still in my practice, and we are growing old together.
Yes, and so I agree with that, and we have scribes in the room to really help with that, as fast-paced dermatology office often does. But I will say that it has helped to see those outcome measures, because sometimes patients don't want to take their clothes off to do a skin exam, and I'll look at them and say, well, your scores are really high, what's going on? And they're like, well, actually, to show you all of what's going on, to kind of introduce the next segments of where to be looking if the patient's impact scores are really high, and that can then trigger a change of therapy that I might not have done otherwise, because people generally want to tell the physician kind of good news, like, I'm fine, but they really aren't. So with that, I'm going to go ahead and close this segment of the chat, and we'll move into the next questions. Thank you, Philip and Jeffrey, who will also join us in the next section, some of the next sessions as well. So session 2 is now on the assessment of psoriasis, so the skin. If you were on prior sessions, the very first one was about disease assessment, so there's a little bit of repeat here. So we'll go ahead to the next question, pre-test question. So the first question, pre-question number 3, is all of the following phenotypes of psoriasis are associated with increased risk for development of psoriatic arthritis except palmoplantar, inverse or intertriginous psoriasis, nail psoriasis, and scalp psoriasis, or scalp psoriasis. So choose one. All of them are associated with increased risk except. All right, and 3, 2, 1. And the poll is closed. So we have a competition here, a little between palmoplantar and scalp. Okay, and so which of these, pre-question number 4 is, which of these statements is true? So this time it's the true one, not the false one. So body surface area and PASI correlate highly with patient-reported quality of life measures. The PASI score takes into account erythema, induration, scale, and body area involvement, or BSA. There is a single common PGA, or physician global assessment, recommended for use in industry clinical trials for psoriasis. Or 4, the PASI functions best when patients have low body surface area. So pick the one that is true. I'll give you a couple seconds here. And 3, 2, 1. All right. So now go into the poll, which 82% said PASI score. And I will go on, but a few people thought that BSA and PASI correlate highly. So we'll hear more about that in a bit. So we'll go ahead into the video. This is Dr. Joe Merola and myself presenting on the phenotypes and disease activity.
All right. Well, on behalf of myself, Joe Merola, and my friend and colleague, who will give herself an introduction in just a moment, we're delighted to share this brief portion on psoriasis, looking at clinical phenotypes, differential diagnosis, really for the non-dermatologist, and then I will turn it over for measurement of clinical activity. I'm Joe Merola, dermatologist, rheumatologist here in Boston, and my colleague.
Hi, I'm Christina Calisteffen. I am a professor and chair at the Department of Dermatology at the University of Utah in Salt Lake City, Utah.
Awesome. I'm very pleased to be here with Christina. And so I'm going to kick us off with some high-level sort of overview content, looking really at a little bit about psoriasis phenotypes. We have a very short time, so it will indeed be a high-level view, and then I'll turn it over to Christina. So plaque psoriasis in classic areas, well-demarcated erythematous plaques on the extensor surfaces, I think is really sort of a largely pathognomonic finding. But let's talk a little bit about some of the lesser discussed phenotypes. I will begin first with a comment about scalp disease. So we know that the majority of our patients have some amount of scalp disease at some point in their disease course, and that's obviously a very important place to look first. The other subsets, or a few of the other subsets that we'll mention, are involvement of the nail, and we'll look a little bit at some of the different specific morphologic features of nail in a moment. Inverse or intertriginous psoriasis, and I definitely want to highlight this as well because it often, I would say, is morphologically one of the more challenging, unless it's unless you're sort of comfortable looking for it and have it at the front of your mind. You may miss this, or it may be misdiagnosed. And then, of course, palmoplantar subtypes and others, which we'll have a look at. So just to take a moment to dive a little bit into this inverse or intertriginous psoriasis, which occurs in body fold areas. This is typically found, for example, behind the ears, in abdominal folds, in the inguinal creases, in the intergluteal cleft, classically. And the reason this is a little bit trickier is you can see it doesn't have necessarily that thick micaceous scale, or it has much more subtle scale. It may simply look like a pink patch or thin plaque, which could sometimes be a bit confusing. In a moment, I'll show you one that was, in fact, went misdiagnosed for many, many years in this patient. So here we see a woman with this submammary or inframammary involvement of a thick plaque with scale. The reason I bring this one up is, an annular scaly plaque is often, particularly in these areas, is often thought of to be potentially fungal in etiology. And in fact, here, this woman had been treated with multiple courses of topical and then ultimately several different oral antifungals for months before she was appropriately diagnosed as having inverse psoriasis or intertriginous psoriasis. So this is a very important one, particularly of relevance to the rheumatologist, as we'll show in a moment, because it may be one of the risk factors for development of psoriatic arthritis. Genital psoriasis, again, we don't have a lot of time to go into great detail, but I will say not uncommon. In fact, about 60% or more of our patients report having ever had genital psoriasis as part of their psoriasis. You can see some of the features here, including cracking and fissuring, that certainly lead to pain, sexual dysfunction, embarrassment. And this really has quite a high impact on quality of life, and something that if we're not asking about, our patients may or may not share with us. They may not even make the connection between the genital lesions and their psoriasis. With regard to nail disease, very, again, high level, we can certainly see classic pits, as well as distal onycholysis at the tip. We can see some oil spots here on this particular photo. And there's some other findings that may also be associated with psoriatic nail disease, splinter hemorrhages. So this is a study we did now a number of years ago. looking at subsets in the Nurses Health cohort in Boston, and you can see the majority of patients reporting plaque disease as well as scalp disease, not surprisingly, lesser palmoplantar involvement in this particular prevalence study, nail disease upwards of 23%, and of interest, a much higher than predicted inverse intertriginous psoriasis rate of almost a quarter of patients reporting inverse disease. So why does that matter to the non-dermatologist? To begin with, obviously we know how impactful psoriasis is on quality of life, and obviously it has relevance in our ability to appropriately diagnose and get patients to the right psoriatic arthritis diagnosis. That said, we also know that several of these phenotypes that we reviewed carry an increased risk for the development of psoriatic arthritis, namely scalp disease, that inverse intertriginous disease, as well as nail disease, and some other factors, including the severity of psoriasis. I raised inverse because for some of our patients presenting with a seronegative inflammatory arthritis, really if we don't see classical plaque disease, it can be incredibly helpful to get the patient undressed and look for some of these more subtle features, including inverse psoriasis, that really, move us over to the appropriate diagnosis of psoriatic arthritis in a patient with inflammatory findings. So with that, hopefully I've shared with you a few morphologic variants. There is always a differential diagnosis. And so if something's not responding to treatment as you might expect, do think about, a local friendly chat with your dermatologist or referral as appropriate. Biopsy is often helpful if there's a question. And remember that intertriginous disease may be a variety of things, including fungal or candidal eruptions. There are multiple different causes for pustular disease, including drug eruptions. Thank you for your attention, and I'm going to turn over control to my colleague who's going to take you on a tour of actually assessing and measuring psoriasis for everyone, actually. Christina.
Thank you so much, Joe. So what's important when we think about measuring or assessing severity? And I think there's kind of an approach here to think about it in clinical practice versus in a clinical trial, but no matter what, the principles still hold true. Good measures require truth. Do they reflect true severity? Are they measuring what they're supposed to measure? Validity? Do they discriminate? Can you tell mild from severe? Can you detect change? And feasibility. Can the provider do it during clinic realistically, or are they able to do it in trial? And there's other obviously attributes that are good, like reliability, et cetera. And those are three attributes are what we call the OMERACT filter. And in all measures, no matter if you're doing them in the clinic or in trials, really need to adhere to those. And feasibility is really important for clinical practice, which is why when you look at this non-Venn diagram where you see only one measure really overlaps, that trial measures, there are a lot of different measures. These are just a few that are commonly used in clinical trials right now for psoriasis. So body surface area, physician or investigator global assessment of PGA or IGA, kind of mean the same thing. PASI, which is psoriasis area and severity index, or classic plaque psoriasis measures. But as we have done the work of Grappa and Idiom and others, really recognize that we need to take a more comprehensive approach and measure nail severity with instruments like NAPSI, scalp disease with PSSI and other global assessments. But in clinical practice, we don't really use many of those things. In fact, sometimes we barely even use simple things like body surface area, because honestly, all those instruments can be a little time consuming, not very feasible, and it's actually a bit difficult to know how to do all of them. And really oftentimes you just see people using descriptions like how the plaques are in certain locations, or they're coarsely described as improved or not improved or the same. So I feel like even in our own dermatology world, these are kind of obstacles to people to do body surface area or PASI and PGA. So in the last few minutes that we have, I'm just going to quickly run through just some pragmatic tips on how to do this very simply, and some resources for it if you want to learn, because I think it is really helpful to have some objective measures you can use in clinic. So the first one is body surface area. Maybe you've seen descriptions of using rule of nines, where you start to go, it's 9 on the arm and 9 on that arm and 18 on the trunk, and then you say, I don't think I want to do this. But really, you can do this very simply by using your handprint as a guide for defining a total body surface area. So the patient's handprint, the whole handprint, including the fingers and thumb, is about 1% of their body surface area. And you can just simply add up the number of handprints. And if you're doing it on telehealth, you can say to a patient, pretend like all of your patches could be pushed into handprint size patches. How many total would it make? And they're pretty good at it. So if they can do it, I think we all can do it. So it's really a very simple thing. If you see here, there are 6 big ovals and then 4 smaller ones, and you push them into handprint size patches, you would get about 7 full handprints. And then taking it to a photo again, just kind of in your mind's eye, thinking how you would do this, again, using his handprint as a guide, you can kind of think, how would you outline a few of the patches and then push the rest together into handprint size patches? And that area that you can see is about 6%. So PASI. So what is PASI? It's the Psoriasis Area and Severity Index. It's the most commonly used severity measure for plaque psoriasis in trials and in many registries, as well as even in regular clinical practice across most of Europe and other parts of the world. The nice thing about this tool is that it assesses both plaque qualities, erythema, induration, scale, as well as the area affected. And most physician global assessments, even used in clinical trials, don't do that. They don't count for area, which kind of leaves out an important domain. It's really pretty familiar to most investigators. It detects change when psoriasis is moderate to severe, which is a limitation if you have low body surface areas, which is a limitation in psoriatic arthritis trials where patients tend not to have as severe a disease. It has pretty good reliability. Payers often ask for it, and it is also part of some rheumatology composites. But when you look at this instrument, as I'm going to show you here, it can be a bit intimidating because you've got to rate erythema induration scale in 4 parts of the body and then do some math to figure out the area score, which uses kind of a, what percentage of the area is affected. And that takes either some math or a calculator. The good news is that we have an app for this. So Grappa a few years ago, which also created not only a PASI component of this, but also an MDA calculator, a PEST calculator, the PSED questionnaire is in there. There's other reference information, so it's a very nice instrument to use, but it can actually calculate a PASI and a BSA at the same time. Basically what you do is just go into the app, and then there's a slider to score 1, 2, 3, 4. There's some pictures there that pop up to show you a guide for what the erythema or the scale or induration might look like. And then you can use that handprint method in the area score. So if you just put in the handprint, then at the end, you will get both a body surface area and a PASI score. So it's 2 for 1. It's pretty useful. It's a free app, and it's on both iPhone and Android. I always tell residents that are in training that this is really an important tool to understand, not just to do it. If you don't want to do it, no big deal. But it's also really important because it's a really big measure for all psoriasis trials. And for most clinical trials for moderate to severe psoriasis, patients need to have a PASI of 12, a body surface area of 10, and a PGA of 3 to get in. And PASI 75 and 90 are new, kind of our standard and the newer endpoints. And all they mean are 75% improvement from the baseline PASI, and the PASI 90 is 90% reduction. And you can see also those correlate pretty well with a physician global assessment. So the last endpoint is the physician or investigator global. And when I say I really don't mean there isn't just one. There are many, many of them driven by a lot of industry and FDA interactions. And so I think that's confusing to people, but at the end of the day, all of them are either a 4 or 5 point scale. This shows you a 5.0 to 4 scale, which is what the FDA in the US likes us to use. And here's just some examples of how the gradations go from 0 to 4, from, clear to, mild, which is a light pink, to light red, all the way up to really a beefy red coloration. Scale goes from, no scale to very sparse, fine, not very much coverage, to more coverage, more coarse, and then total coverage where you can hardly see the erythema. Induration's a little trickier. I think if you think of this as a millimeter as a 4 and everything else is a 1/4 of a millimeter less, that's generally how we do it. So these instruments, just like any instrument, have limitations. And one of the things that they kind of fail on, which is ironic in a way, is that they don't correlate super well with disease severity from a patient standpoint or from a patient-reported outcome standpoint. So you can see here a patient who has practically erythrodermic hands has a body surface area of 2% and a PASI of 3.6. That sounds really mild. And the patient with scalp disease, a body surface area of 2% and a PASI of 3.6, inverse 1%, PASI of 1.2. But there are some new studies that have come out, one that'll be presented this year at the AAD, that really suggest, based on registry data, that patients with low body surface areas, but in special areas like this, like your psoriatic arthritis patients, actually have much worse scores on patient-reported outcomes. And even if they had all of these phenotypes, body surface area of 8%, PASI 7.2, they wouldn't even make it into a clinical trial for a moderate severe disease study. So last is patient-reported outcomes, which I'm just going to touch on, which is the future is now. This is actually a screenshot from one of my patients' charts where we use an instrument called Skindex and also PROMIS depression and physical function. And high scores of the Skindex correlate with worse quality of life. Low scores are basically correlating with clearance. And you can see that it kind of goes the wrong direction, but from March of 2019 to August, I put this person on a therapy that basically cleared their skin, and you can really see how nicely their scores come down. There are very quick tutorials on how to do each of these that GRAPPA and the AAD partnered with. And that is, I think, the end of my slides. So thank you very much. And thank you, Joe, for your partnership.
Thank you.
All right. So we'll jump right into the post-test questions. We're running a little bit behind, so I might fly through these bits. Okay, question number 1 was all of the following phenotypes are associated with increased risk for development of psoriatic arthritis, except which one? Palmar-plantar, inverse, nail, or scalp psoriasis? Three, two, one. Right. So the answer from the presentation goes into how palmar-plantar is less associated with psoriatic arthritis development, which came from a 2016 study. Some people answered inverse. I feel like maybe this was a little bit of a trick question because there is a registry called Corona that we're doing, and there's some data suggesting palmar-plantar psoriasis may in fact have a little bit of an association, or maybe seen a little more commonly people with psoriatic arthritis. So maybe the answer is not clearly that, but definitely scalp, nail, and inverse disease are more associated. So question number 4, which of these statements is true? Body surface area and PASI correlate highly with patient-reported outcome measures. The PASI score takes into account erythema induration scale and body area. There's a single common PGA or IGA recommended for use in industry clinical trials. And the PASI functions best when patients have low body surface area. Which one is true? All right, and 3, 2, 1. The answer is number 2. You all had, a lot of people had this right the first time, so we've improved a bit here. Body surface area and PASI in clinical trials do not correlate highly. They correlate somewhat, fair to good. So the best answer of these was the PASI. I already said in the presentation, there is no single common agreed upon physician global or investigator global. There's a lot of different ones. And the PASI functions best when the patient has higher body area. At lower areas, it's not very granular, so it doesn't work quite as well. So I'll go ahead and invite my my two partners here, Dr. Meese and Jeffrey Chow, again back in for a very short moderated discussion. We don't have a lot of time because we're a bit behind. But I wanted to ask a question of Philip about the exam and the phenotypes and kind of your thoughts on the importance of rheumatologists understanding those phenotypes, and then maybe also assessing skin disease at each visit. Because some people might say, well, I'm not a dermatologist, so this is really the dermatologist's job. And also, I'm not going to do a PASI every visit. So how would you respond to that kind of part one, part two?
Well, the first comment to make is I don't know anybody who does a PASI that's outside of a trialist dermatology arena. So either people that are in dermatologists that are in trials or registries do PASIs. We're capable of doing PASI scores in clinical trials, but it's way too complex to do in practice, and the calculation is difficult. So we do end up doing a what is called an investigator global or a static physician global. That's part of the psoriatic arthritis corona registry. We include that, and I think it's a bit better than just the body surface area. But as I mentioned before, when I was trying to hype the MDA and how easy it is to use, there it is, 1% of my body surface area. Patient's handprint, 1% of body, their body surface area. That's the quick and dirty way of doing that. In terms of phenotypes of psoriasis, that's a fascinating and important question. I don't think rheumatologists really get it in terms of the different varieties. I don't think that they know much beyond plaque psoriasis. I don't think they know erythrodermic or guttate. I don't think they look on the soles of the feet, and that's sometimes the most bothersome place for patient is involvement of the soles of the feet. And I never know whether that's fungus or psoriasis. And I desperately need my dermatology colleagues nearby to teach me and help me with that. So very much so when it comes to all the various subtypes that you and Joe were commenting on, which I always learn, even at my age, I'm learning more every time I listen to you guys. I think that it's an important area for us to learn about in rheumatology, just for appreciating it. And we're not going to go about seriously assessing it, but appreciating it.
So a couple of rheumatologists have weighed in and said that they do PASI scores in some areas of the world. It is standard of care for dermatologists, not so much the U.S., but in our payer environments, our insurance environments, we often need one to get a drug, a biologic in particular, approved. Jeffrey, a question for you about skin assessments. Do you feel like it's important for physicians, both derms and rheums, to do a skin assessment at each visit? A lot of times patients will say, I'm totally clear. I don't need you to look at my skin. So what do you think about that?
Actually, in my experience, time is very limited in every clinical visit. So for the rheumatologists, they mainly, because we feel pain and fatigue, and we want them to deal with our joint problems. So when we see, within a limited time, when we see the rheumatologist, we want them to focus on our joints as well. But on the other hand, for the dermatologist, every time I went there, they would ask me, how's my PSA doing, and am I still taking this same PSA medication? So they will ask for the dermatologist, but for the rheumatologist, in my experience, it's mainly focused on the joint problems.
Well, thank you for both for that, and I think everybody should do one every time because it's my only way to know if a patient has responded. So my quick answer is yes, we should try to at least do a BSA at each visit, and certainly look to see in those sort of hard to treat areas if there's activity. Sometimes patients won't volunteer that. So I'm going to go ahead to the last part of the session, so session 3 on axial spondyloarthritis. And I'm going to introduce Dr. Atul Deodar, who's going to join us for the moderation at the end. He's in the background listening now. And as I said before, he is a professor of medicine at Oregon Health Sciences and a rheumatologist. So go ahead to question number 5, pre-test question number 5. And so MRI finding of BME in posterior lower ilium and anterior upper sacrum can. So choose one. Allow for early diagnosis of axial SpA and inflammatory back pain. 2, be used for assessing disease activity of axial SpA. 3, distinguish axial SpA from degenerative pathology. 4, lead to overdiagnosis of axial SpA. Or 5, unsure. So I'll give you a few seconds. Three, 2, 1. Poll is closed. And so we have a smattering of answers, so hopefully we will hear about that, and I assume we'll hear about that in our session here next. Okay, pre-question number 6, axial mobility measurements or metrology in axial spondyloarthritis patients. Number 1 is a measure of change, not status. Number 2, cannot measure disease activity. Number 3 is a measure of structural damage alone. Or number 4, depends on disease activity and structural damage. So submit your answer now. 3, 2, 1. So majority answer number 4. And we'll go ahead and go into our last session here, last presentation.
Hello, my name is Atul Deodar. I'm a professor of medicine at Oregon Health and Science University, Portland, Oregon. And I'm going to discuss the topic assessing disease activity in daily clinical practice, axial spondyloarthritis. So the first question we have to answer is, why should we assess disease activity in clinical practice? And what this cartoon shows us is the relationship between the disease activity or inflammation and damage and disability. At the lower left side, what you see is a patient who's disabled, and we are trying to avoid disability in our patients. It also shows that inflammation leads to reversible disability. At the same time, inflammation can lead to irreversible damage, and damage can lead to irreversible disability. So if we have to avoid disability, we have to prevent and treat the inflammation actively. Now, we are rheumatologists. We treat inflammation better than anybody else. And that's the reason why we should be assessing disease activity in clinical practice, so as to prevent damage and so as to prevent disability. So then the next question is, how do we assess disease activity and how should we assess disease activity? So on the left hand side, you see what happens in daily practice. We take the history, we do physical examination, we do labs, and then we do imaging at some times. All of this gives us some idea about the disease activity, history like pain and swelling and stiffness and fatigue, and the physical examination, and then the inflammatory markers. MRI can give us some idea about disease activity. But then what will add value to what we routinely do? And the answer is the composite measures of disease activity, BASDAI, ASDAS. And I'm going to also put in the plug for RAPID-3 as a method of assessing disease activity. So in the peripheral skeleton, you have already heard about this in the psoriatic arthritis talk. 66, 68 joints, enthesitis, and there are several enthesitis indices and dactylitis, and I won't go into the details of those. For the axial skeleton, spinal mobility measures are what we do. Think about it though. Do spinal mobility measures really assess disease activity? And we'll come to this in a minute. Cedrate CRP, yes, and then there are those BASDAI, ASDAS, and RAPID-3, the composite measurements of disease activity. Before we go any further, I want to make an important point. We should not confuse change measures versus status measures. Change measures don't tell us anything about the patient's current status. They only tell us how much they have changed. Have they improved by 20%, 50%, 40%, etc. Examples are ACR 20, 50, 70 or ASAS 20, 40, etc. On the other hand, status measures don't tell us whether the patient has improved or not, but status measures tell us how the patient is doing. All the disease activity measures are status measures. So peripheral skeleton, and I'm not going to go into the details of this. You already have heard about this in the psoriatic arthritis talk. For the enthesitis, in my practice, I do a hybrid measurement of Achilles tendon, plantar fascia, quadriceps, patellar tendon, lateral and medial epicondyle, and I do the joint counts. For the axial skeleton, I do the axial mobility measures. Now, axial mobility measures, do they really measure disease activity alone? The answer is no. They do have, the disease activity definitely has an effect on the axial mobility measurements, but the axial mobility measurements depend upon the damage, and they also depend upon the age, the sex of the patient. What I do in clinical practice is tragus to wall, occiput to wall, 10 centimeter Schober stress, and lateral spinal flexion. That's what I do in my daily practice routinely. That brings us to the disease activity measurements such as BASDAI and ASDAS. BASDAI has 6 questions. The scale is 0 to 10. Completely patient driven. ASDAS has 5 elements. There are 3 questions from BASDAI, and there is 1 extra question about patient's global disease activity. And then there is either Cedrate or the CRP. This is BASDAI. It takes about 2 minutes for the patient to fill out. It takes about 1 minute for us to score. The minimal clinical important difference, or MCID, is 1 centimeter. ASDAS is another very validated measurement. It was devised because BASDAI is purely patient driven. So this one has, as I said, 3 BASDAI questions, 1 patient global activity measurement, as well as CRP or Cedrate. And it has a very complicated formula. These are the cutoffs, and I want you to look at the bottom part, the 2018 update. ASDAS of less than 1.3 is inactive disease, 1.3 to 2.1 is low disease, 2.1 to 3.5 is high disease, and anything above 3.5 is very high disease activity. Now, ASDAS is a status measure. It tells you about the patient's disease activity. However, ASDAS can also be used as a change measure, and here it is shown that the change in ASDAS of 1.1 or higher is clinically important improvement, and change of 2 or higher is major improvement. So the same measure we are using as status measure and change measure. So what is feasible and what is simple and what adds value? Now, ASDAS is validated. It definitely adds value, but in the United States, we certainly don't have C-reactive protein available at point of care. BASDAI is validated, simple, feasible, and does add value. We started wondering whether RAPID-3 can be used because it's the most commonly used tool in the United States. And we did a study on 157 ankylosing spondylitis patients that we followed for about 5 years, and we did cross-sectional longitudinal data about the BASDAI and the RAPID-3. And we found out that RAPID-3 correlates very well with BASDAI, and it has an advantage of providing information about the patient function in addition to the pain and stiffness. We also found out that BASDAI of 4, which we take as anything above 4 we consider as active disease, correlates very well with RAPID-3 of 3.3. Remember that BASDAI of 4 correlates with RAPID-3 of 3.3 and higher. That brings us to the next big topic, which is MRI of the sacroiliitis. Now, MRI of the sacroiliitis, or MRI of the sacroiliac joint, I should say, is the only objective sign of inflammation at the target organ that we are interested in axial SPA, and that target organ is sacroiliac joints. The definitions are changing. These ones are the newer definitions. The bone marrow edema, abnormal fluid signal indicating active sacroiliitis, shown on the top left. Now this is looked on the STIR image, which is a fat suppressed T2 weighted image. And the next three, the right upper and both lower, are on the T1 weighted image where the bright signal is fat. And that particular figure, or those particular signal and images, are important for erosions, ankylosis, fat lesion, etc. These are post-inflammatory changes. When should we reorder an MRI? We can order MRI for diagnosis, but we are thinking about disease activity. The 2019 update of the ACR SAA Spartan treatment guidelines say that routine monitoring of MRI is not recommended. They say we conditionally recommended obtaining a spinal and pelvic MRI to assess activity while the patient is on biologic, only if you are suspicious whether, or if you don't really know whether the patient's condition is active or not. That's the only time that you would repeat an MRI in daily practice. I want to show you a few slides about the caveats. All the disease activity measures in axial SPA have caveats. So apart from CRP and sacroiliac joint MRI, everything else is patient reported, and that heavily is affected by the patient's mood, anxiety, depression, and distress. Daily stressors affect the patient's fatigue, pain, etc. On the right hand side, I've given you two references which show the relationship between the disease activity measured by BASDAI and the psychological status and stressful life, etc. CRP, which is an objective measure, is neither sensitive nor specific. MRI is too expensive. We don't repeat it routinely. So ultimately, for disease activity, clinical judgment is the key. I want to give a shout out to this paper by Jean Liu, and this was published last year in ACR Open Rheumatology. Effect of stress and anxiety on the axial SPA disease activity. So Jean looked at the SOAS database and looked at the patients in the SOAS database during the pandemic. And she found out that after adjustment for potential confounders, those with higher levels of stress had 0.54 point higher BASDAI compared to those had lower levels of stress. In other words, stress, depression, anxiety can increase disease activity. So ultimately, it's your clinical judgment that is what is important. Well, what about CRP? I mean, that's objective, correct? So there was a study that was done on tocilizumab, an IL-6 receptor antibody, and they found out that it works dramatically on ASDAS reduction because ASDAS is so much dependent on the CRP. However, tocilizumab had no effect on the patient-reported outcomes. So CRP might drop like a stone in drugs that reduce the CRP or act on the IL-6, but that also is a caveat. That brings us to MRI, and MRI has caveats too. As you know, active MRI or positive MRI, if there is a signal on the STIR image in the posterior lower ilium or anterior upper sacrum, those are the two areas which are most commonly affected, even in normal people, in athletes, in mechanical back pain, etc., etc. So two white spots on the MRI on the STIR image is objective but not specific. In other words, every measurement for disease activity in axial SPA has caveats. Beware of them. Finally, how do we assess disease activity in the era of telemedicine? Telemedicine is here to stay. Even post-pandemic, we are going to be using telemedicine as we are getting more and more comfortable. Here, history becomes most important. I ask my patient about their pain, their spinal pain, and I, in fact, fill out the BASDAI and RAPID-3 by asking the patient directly questions, and I'm filling it out by asking them those questions. There is a brief physical examination I'm going to show you on the next slide, what you can do on telemedicine, which gives you an idea about the disease activity. Ultimately, you tell the patient, send me the photos of your swollen joints and rashes and etc. And labs, of course, are become very important. Here is my patient who's showing me, and actually you can see even my photograph in the lower corner in those pictures there. The physical examination that I do are MCP, PIP, DIP, synovitis. Here the patient showing me his hands and then showing me this way about the knuckles. Patient reported swelling, dactylitis, deformity. I asked them, send me a picture. Is any toe swollen like a sausage? And then the palm size 1% body surface area for psoriasis is also very important. We are learning different ways of doing physical examination during virtual visits and assessing the patient's disease activity. In summary, persistently high disease activity in axial SPA leads to disability directly, that's reversible, and indirectly through skeletal damage, and that is permanent. We need to prevent that, and that's the reason to assess patients' disease activity in daily clinical practice. In daily practice, we assess the axial SPA disease activity by history, physical examination, peripheral and axial skeleton in examination, as well as lab investigation. And then we should be using the composite indices of disease activity, such as BASDAI, ASDAS, if it is possible, definitely. And RAPID-3 is what we use along with BASDAI. Longitudinal assessment and tracking patients' progress becomes very important. MRI of the SI joints and spine should be reserved in patients on biologic where disease activity is unclear. Thank you for listening.
So we will do our final post-test questions here. So we'll go to question number 5. MRI findings of BME in posterior lower ilium and anterior upper sacrum can allow for early diagnosis of axial SpA and inflammatory back pain, be used for assessing disease activity of axial SpA, distinguish axial SpA from degenerative pathology, lead to overdiagnosis of axial SpA, or unsure. All right, 3, 2, 1. We're going to close the poll. All right, so there's some people answering lead to overdiagnosis and then allow for early diagnosis of axial SpA. So the answer is lead to overdiagnosis of axial SpA. Just to the point that it, depending solely on bone marrow edema, can lead to overdiagnosis, and that it's, I guess, not that uncommon in healthy volunteers, degenerative pathology in athletes. So go ahead to the next question. Axial mobility measurements or metrology in axial SpA patients. 1 is a measure of change, not status. 2 cannot measure disease activity. 3 is a measure of structural damage alone. 4 depends on disease activity and structural damage. I'll give you a few seconds. And 3, 2, 1. Right. So majority answered. Depends on disease activity and structural damage. A few second and third place questions were measure of change, not status, and can't measure disease activity. So the answer is on the next slide, which was number 4, depends on disease activity and structural damage, as both can affect axial mobility. So I will go ahead and reintroduce our final panel, and I think Dr. Deodar is going to be able to stay on for just a minute. We all have busy lives being on call. I think some of us are on call this evening, and so I don't know if he's going to be able to join. Oh, there he is. He said he would join for a minute, so yeah.
Atul, we can't hear you. I think you're on mute.
Oh, I think he now turned his video off. Okay, we'll get him back. I think okay, we can hear you now.
Can you hear me?
Yeah, we can hear you. That's probably more important than being able to see you.
Neither the video nor the audio is in my hands. They turn me on and off.
Yes, and then when you try to intervene, sorry, it's like technical
Yeah.
thank
No, I
you
can,
for-
I can certainly stay. I'm also on call, but I got 10 minutes. I can certainly stay. Absolutely.
So
I think
Atul,
we're-
both you and I are on call.
Yeah.
And I was telling Christina earlier about a patient that I saw in the hospital yesterday that has a CRP of 444.
Oh, is that right? Yeah, yeah. We have somebody I'm going to go and see, which is leptomeningeal enhancement with 250 CRP.
Oh, no.
But we have a patient.
Sorry,
psoriatic
Philip
arthritis.
wins. Philip wins tonight. Okay, I'm going to ask. Jean Lu put into the comments here about saying thank you for mentioning her study, their study. So,
Jean. We miss Jean here. Jean is a OHSU product. But we love her.
so
And
second,
the University of Washington.
Yes, fair enough.
So thank you for joining us. So the question from Jean was, how do you see the incorporation of further telemedicine-based measures of disease activity as we hopefully shift out of the pandemic?
Yeah, so that's a great question. And we are actually struggling with that because every time when the patient came to OHSU's rheumatology, we were doing, and Jean knows, we did this rapid 3 on everybody for any disease, follow-up, new patient, etc. And because of my interest, I would get BASDAI done. And now with telemedicine, it has become quite difficult to get these things filled out. As I said in my talk, I ask the questions about, there are 6 questions with BASDAI. I ask them on a scale of 0 to 10 how much that is, and I can fill that up. Rapid 3 is somewhat difficult to fill. But you spend time in that, and patients get confused and they cannot really answer the question quickly. We are trying to find out a way of sending these things beforehand to the patient and then for them to fill it up and sending it back. Not all patients are that computer savvy, as you know. People are having difficulty in just to get onto the video visit. Several times we do telephone because they cannot really log on to this. Hopefully, as we shift out of pandemic, we are actually going to increase. We are getting back to face-to-face. We probably, my university is going to have 20% of virtual visits. That's what they're saying indefinitely. 80% face-to-face, 20% virtual is my university's idea. And it is somewhat difficult how to get these forms filled out and people join at the very last minute. We need to find ways and means of doing it better.
We are also finding that we're quite involved in long-term research registries.
Yeah.
And what we're finding is that we can capture quite a lot of information through patient-reported outcomes, as well as reporting on what we discussed during our virtual visits. We can do some skin examination, although not as good as you can, Christina. And we also are able to do some of the things that Atul was showing to get at things like dactylitis and so forth. So it's a little surprising how well we can do, and the patients can fill out their PROs online.
Yeah. Another question here is where do you feel the bigger need or opportunity is for education on correctly interpreting MRIs for AxSpA, rheumatology, radiology, other?
Yeah, and thanks, York, for that question. So certainly musculoskeletal radiologists, so most of the research that we are having in MRI of the sacroiliac joint is happening in the rheumatology world, and it is published in the rheumatology literature. So the radiologist, musculoskeletal radiologist, may not be as familiar with what we are publishing here. So definitely musculoskeletal radiologists need to be educated, but at the same time, I find that reading MRI should become part of rheumatology fellowship. We learn how to read X-rays quite well during rheumatology fellowship, but MRI reading is not part of rheumatology fellowship. Ultrasound has seeped into rheumatology fellowship, and I think MRI should be the next sort of imaging modality that rheumatologists need to at least get familiar. I mean, you may not be able to read very well, but at least need to know what is T1, what is T2 weighted, what are the structures, etc., etc. And for sacroiliac joint, I think it is important that we understand what they show, and at least smart enough to quiz the radiologists. So it's both. I think the musculoskeletal radiologist and rheumatologist, and it definitely should be part of rheumatology fellowship. And I'm hoping it will become, just like ultrasound. It has taken years for us to learn ultrasound, which Europeans were already learning way back.
So I have another education question, but for Jeffrey, when so Philip started by saying that there's the Brooklyn screening of hi, how are you? And the dermatologist screening for rheumatologic complaints is, do you have any joint pain? Which they probably ask with some concern of taking too much time, but unfortunately. But I don't think patients often correlate joint pain and back pain. So how can we better educate patients on hey, if you have back pain, that this could be part of your psoriatic disease or SPA?
I think to start with, if the doctor asks, then it's easier for us to respond. But as a patient group, we always have some education talk. We invite the doctor to come, and then maybe if the patient know that it's important, they will report it. Otherwise, they just skeptical and time is so limited, and they don't speak out. So I think education is important.
Very good. I think we've been through all of the questions in the chat. Any other last comments?
Yeah. Christina, I want to bring something up which we haven't yet in all of the talks this evening, and that is that this whole subject of how we get around the confusing aspect of fibromyalgia or central sensitization. So the percentages are significant. Theoretically, 15% of our patient populations, whether it's AxSpA or PSA, I don't think psoriasis, but certainly the musculoskeletal conditions, have overt fibromyalgia. And 30 to 50% will have some degree of what we call central sensitization, or a certain degree of upregulation of their nociceptive neuropeptides in the interpretation of pain. And so we've learned over the years that will screw up our ability to really assess disease activity in the ways that we've been teaching today. Because every time you have anything that has a subjective element to it, people with a certain degree of central sensitization, their numbers will be higher. Their disease activity will be reflected as higher. They won't have as much improvement with treatment, and so on. And so it's very important for us to take this into account, to have it as a contextual factor, to have a sense of whether the person in front of us has some degree of this, not to judge them negatively for it, because a lot of this is genetically programmed, and it's not their fault that there is this central sensitization phenomenon. But we maybe don't need to just jump to changing biologics so quickly. If the patient has a high degree of central sensitization, and maybe we should be doing some other things, mindfulness meditation, getting patients to do yoga, Tai Chi, getting patients to go swimming, doing things that take into account their whole experience holistically. So I just wanted to make sure that we have that there. And I know that Ashish, one of our colleagues who's doing some advanced imaging work, is really curious about this and how we can use ultrasound or even MRI to help distinguish the patients that have true itis or inflammation in some of these areas, and a certain degree of algia as the reason for their pain.
Yeah, I think that's an excellent point. And I think, in the talk, Atul's talk about the paper about the impact of mental health and severity of disease and mobility, the same kind of thing is true in psoriasis. So I think that's, again, what's so great about having patient-reported outcomes throughout all of this is that we have to be able to treat the whole patient. And certainly fibromyalgia, teasing that away from this, that apart from inflammation is a challenge. And I think there was one other question that Ashish Matthews had also asked, which was about, and maybe it's more of a derm question, like when you order an MRI, should we also include the spine imaging, like X-ray, et cetera? Like, do you feel like that's, I guess maybe you guys generally do them in order, you get an X-ray and then you get an MRI, but yeah. I sometimes tee people up to send them to room consult. Should I just get those things for you, or do you want to do the ordering?
Yeah, no, I mean, so for the spine, just getting back to Philip's point, for psoriatic arthritis, at least you can examine some joints and you can, whether there are swollen joints and tender enthesis, and sometimes enthesitis can be confused with fibromyalgia, tender points also many a times. For axial skeleton, there is hardly any real examination about knowing whether there is inflammation or not. Physically, you cannot really examine the joint, the spine, and decide whether there is active inflammation. And there, then definitely the fibromyalgia or stress or mechanical pain, or it's very difficult to know. Patient-reported outcomes will not be different between mechanical back pain and when there is real inflammation, sacroiliitis. Getting back to your thing, I mean, the MRIs are MRI of the sacroiliac joint is very important. Unfortunately, what has happened is choosing wisely this campaign, which is very important. Primary care doctors have been doing unnecessary, well, I don't want to generally slam everybody, but then generally there have been much more MRIs done of the lumbar spine for mechanical backache, which is not very essential and which is not very informative. And because of that, the American Medical Association, one of their main choosing wisely campaign was for mechanical backache. Don't do even X-ray if you know, let alone MRI. And that happened because people were doing more and more MRI. So here we are now in rheumatology, and we are telling people that no, you need to have MRI more because the inflammatory back pain concept is not that good. Inflammatory back pain is just a clinical construct. It's not really a disease. And several people with inflammatory back pain have nothing. And several people with mechanical back pain, in fact, might have this. So MRI is very important. And then now we are kind of getting against this push in medicine to save money and to choosing wisely. So getting back to your point, Christina, I don't know that people should be already doing X-rays. X-ray, yes, X-ray of the sacroiliac joint before referral is a good idea, but already ordering an MRI may not be a good idea. I mean, we have to really use our judgment only because MRI is so very expensive, and we have to be choosing wisely.
Yeah, thank you for your comments. So we're a bit over our time. So I think I'm going to go ahead and close the show here and say thank you to everyone. I would like to just say a few words to close up. First of all, I wanted to say thank you to all of the audience, all of our attendees for attending and for all of your excellent questions and comments in the chat. We really appreciate that. Second, I want to say thank you to all of the faculty who were here tonight or who did presentations, and mention a couple other people who I failed to mention in the first round. So Jeffrey Chow, thank you for joining us, with Martin DeWitt, our other PRP, along with Dr. Coates, Dr. Didar, Dr. Leong, Ashish Matthew, who was asking some of the questions in the background for us, Dr. Meese, Dr. Marola. And then I want to say a special thank you to Dr. Philip Hellawell, who's really been heading up this whole show, who wasn't on tonight, but has very much been engineering things in the background for this whole series. So I wanted to say thank you to him. I wanted to then also say thank you to Spartan and Grappa, the folks who also behind the scenes make this possible, Lisa Spiegel from Spartan and Janine Coack from Grappa. Thank you to Nucleus, who made this whole show go very smoothly. So they're in the background, muting and unmuting us. So thank you for the smooth transitions, the questions, and all that. There are 3 more seminars in the series coming up. Comorbidities and burden to patients is next one, followed by the global perspectives and new therapies and developments, where hopefully we can get more into treat to target. I think somebody asked about that earlier. Hot topics, race, age, sex considerations will be the final presentation in June. Again, want to say, and I said this in the chat, but all the presentations that you've seen today, all the other ones are on demand. The ones that haven't played yet won't be on demand yet, of course, but they're all recorded and they're all on demand on both the Grappa and Spartan websites. I want to again say thank you to Pfizer, our sponsor, for putting on this cutting edge 2021 Global Education Seminar. It's great to see everybody, at least virtually, in this way. And with that, I'm just going to wrap it up and say again, thank you to everyone here tonight.
Thank you.
Thank you.
Bye-bye.
Bye-bye.